my talk is supercapsule reconstruction for massive rod cuff tear. Here's my disclosure. We developed a new surgical treatment of supercapsule reconstruction for irreparable cuff tear in 2007. This is an animation movie. We insert the two suture anchor on the grinder. Usually it's a 4.5 millimeter, and laterally my prefer is a speed bridge, and all sutures and fiber tape attached outside the body then not tying on the grinder first, and laterally speed bridge with medial mattress suture, and finally set the suture between graft and tendon. Also, I'm showing how to make a fasciolata graft. This is a fasciolata. Fasciolata has an intermuscular septum there. If you include intermuscular septum, it's a tendon tissue. Then we can make a thick graft. We sandwich this intermuscular septum in between two layers and medial mattress suture, very important to make stiff graft. Until last year, we have done around 700 cases of SCO. And based on my clinical experience, today I'm showing the current indication of SCO for irreparable cuff tear based on the Hamad classification, brutal grade, sports activity, physical work, pseudoparalysis before surgery, and concomitant irreparable subscapular tear. First, Hamad classification. Actually, from grade 1 to 5, all Hamad classification is the ideal for fasciolata issue, but actually grade 1 to 4B, we do arthroscopic supercapsule reconstruction, but 4B in old patient and 5, we do total shoulder plus issue. But maybe some doctors do using dermagraft for issue, but the dermagraft issue, maybe the grade 1 and 2 are ideal, but the grade 3 to 5 gray zone or contraindication because of lack of super stability, even after dermagraft issue. I'm showing some cases, Hamad grade 1, after issue, graft is intact there and good elevation. And grade 3, after issue, increase equidistant and the graft is intact and good elevation. And this patient had grade 4B in young patient. We did the issue for this patient, and after issue, good elevation. But actually, this patient had pseudoparalysis before surgery. And grade 4B in old patient, this patient, we did total shoulder plus issue. Then, after total shoulder plus issue, good elevation and good external rotation without any pain. And next, gluteal grade. For any gluteal grade, fasciolata issue is ideal. This patient had actually gluteal grade 4 in supraspinatus and infraspinatus muscle and subscapular muscles before issue. Then 10 years after issue, graft is still intact, but actually supra-infra subscapularis gluteal grade 4. And 10 years after issue, still good elevation and good external rotation, and he's still doing carpenter actively. And sports activity, fasciolata issue is ideal to return to sport in irreparable rod cuff tears. This patient had 3 tendon tear before surgery, and 1 year after issue, he returned to the baseball. And next, physical work. Fasciolata issue is also ideal to return to physical work. This patient has 3 tendon tear before surgery, and now he returned to the as a gardener, and no pain at all. And the next, pseudoparalysis before surgery. Fasciolata issue is ideal to recover pseudoparalysis. This patient, this is the average data of active elevation. If the patient does not have pseudoparalysis, good elevation and around 60 degrees after issue, and even the patient has moderate pseudoparalysis or severe pseudoparalysis, the active elevation significantly increased around 150 degrees. This patient with carpenter and very limited elevation without any pain, and even after lidocaine injection, he couldn't elevate arm at all. And its MRI shows irreparable massive tear, and 3 years after issue, graft is still intact and good elevation, and he's working as a carpenter. Next, concomitant scapular steer. Now I can say it's a gray zone for Shirata issue. This is average data of the active elevation. There are no subscapular steer group, the good active elevation after surgery, 55 degree, and the reparable subscapular steer group, we did SCR plus subscapular repair, then good elevation around 157 degree in after SCR. But reparable subscapular steer group, in this series, we did only SCR. We did not treat subscapular steer. Then active elevation, the increase, but actually post-operative active elevation in this group was significantly less than the no subscapular steer group and reparable subscapular steer group. And this patient had irreparable supra and infractional tendon tear with reparable subscapular steer. After the surgery, and distance increased and graft was intact, and repaired subscapular steer is intact. And after surgery, good elevation and good internal rotation. And he returned to the carpenter at 6 months after issue. And this patient has a supra and infra and subscapularis irreparable subscapularis tendon tear. And before surgery, very limited elevation and limited internal rotation. Then after SCR and graft was intact, but subscapularis still no change because we did not treat at all. But actually the elevation increased and the internal rotation also increased, but muscle strength, the internal rotation, it's not so strong. That's why I can say it's a gray zone. Finally, I'm showing my indication of reverse shoulder arthroplasty, meaning the contraindication of SCR is a failed total shoulder arthroplasty birth defect, chronic shoulder dislocation in old patient, Hamad grade 4B or 5 with irreparable subscapular tear, and irreparable tear in all 4 rotator cuff muscle. Thank you for attention.